Hello and welcome. We will take a few moments to let people join the webinar and then we will get started. Okay, thank you for joining us today. This is TMA's Myositis Research Webinar Series, where every other month we spotlight a researcher's work in the myositis community. My name is Rachel Bromley, and I am TMA's Senior Manager of Patient Education, Support, and Advocacy. And today we have with us Dr. Helene Alexanderson, and her big topic is going to be exercise. Did I say it right?
Yes, perfect.
Yay! I practiced. So it's so nice to have you. Thank you for taking the time out of your busy schedule to share your expertise with us. We're really looking forward to hearing what you have to say and what you've been working on. And go ahead and give us a full introduction of yourself, if you don't mind.
Thank you so much for that kind introduction, and thanks for having me. So my name is Helene Alexanderson, and I'm a physical therapist. I've been working in the field of rheumatology since about almost 30 years. And I spent most of these, all of these years seeing patients with myositis and focusing my research on myositis as well. So I'm at Karolinska University Hospital and Karolinska Institutet in Stockholm, Sweden. And I'm on my second round now. I'm very glad to be re-elected again to the Medical Advisory Board of the TMA. So I have attended, I think, 6 conferences over the years, and I have really enjoyed meeting all of you and also the other myositis experts, and I've always learned a lot. So I'm very happy to be back. So
that's great. If you want to go ahead and share your slides, and we can talk about what you've been working on.
Yes, let's see. Hey, sorry. I think I shared the wrong. This one.
At least it wasn't like your grocery list, your shopping list or something.
No, it wasn't that bad. Okay, I hope that you can see my presentation now.
Nope, not yet.
Not yet. No?
Nope.
Strange. It worked before.
Yeah, we practiced and everything.
Does it work now?
Nope.
What can I do?
You hit the share screen at the bottom?
Oh, maybe I didn't. I'm sorry. Okay.
Perfect. You can just put it in presentation mode. Yep. And we're good to go.
Thank you. You never quite learn. Okay, so today I am going to talk about my 2 main focus in research, and that is the development and validation of clinical outcome measures for people with myositis. And then, of course, I will talk about effects of exercise, both on like quality of life and muscle function and aerobic capacity, but I will also talk a little bit about what happens in the muscle and what led us to believe that exercise is actually a disease-modifying treatment in myositis. But first, I'm going to talk a little bit about a measure that I developed during my PhD studies. It's called the Functional Index 2, and it's an assessment of mainly muscle endurance in people with myositis. So it measures function in 7 different muscle groups, and this measure I do first time I see a patient with suspected myositis, just to do a screening of where the patient is affected, in what muscle groups. So then if the patient is really weak, then it doesn't take so long time. And if the patient has a very good muscle function, then it can take up to 35 minutes to perform. So it's very simple. I don't need much equipment. But what is special here is that I use a metronome, and that is, I bought it in a music shop, and it helps me to keep the right pace. So for example, for shoulder flexion, you should do a pace of 40 beats per minute. And if you're testing the more distal muscle groups of the legs, you do it in a faster pace. And I also ask the patient after each of these tests, so how exerting was it in your muscle when you stopped? And you can find this instruction film of this on YouTube if you search on Functional Index 2 myositis. And if you're interested to test this, you can show this to your physiotherapist or your rheumatologist or neurologist. So maybe this is something that you can perform at your clinic. But it's basically, I ask the patient to perform as many repetitions as possible, or continue until I say stop. So I guess most of you have at your doctors, they have done the manual muscle test, 8 or 15 muscle groups. This is the manual muscle group, manual muscle test of 8 groups. So this is % of maximal score. So if you're below here, you're very weak with 0, 20, 40, 60, 80, and 100% of the maximal score. And on this axis, you see the % of the maximal score on the Functional Index 2, the pictures I just showed you. And what is interesting here is that most patients perform very well on the manual muscle test. So it basically is between 60 and 100% of maximal score. But the same individuals, you can score 100 on the manual muscle test, but the same person is scoring 0 on the FI2. So it seems like the functional index is it's better to detect a muscle impairment in people with myositis. So we can go back to this slide later if you have any questions. So at the Karolinska, and I believe in many other centers in Europe and maybe in the US, we measure both of these. Both the physician do the manual muscle test, and the physiotherapist can do the functional index 2. And during my postdoc at the Mayo Clinic, we discussed that the physician will never have the time to test all of these muscle groups during their time with the patient. So therefore, we developed a shorter version of the functional index 2 called the functional index 3. And this is just 3 of the muscle groups: shoulder flexion, neck flexion, and hip flexion. And this is scored on how the patient is performing on the dominant side, and of course the neck flexion. And these are the 3 muscle groups: shoulder flexion, neck flexion, and hip flexion. So this is a much shorter measure. It takes a maximum of 10 minutes. And you get quite a good idea on the patient's strength or muscle endurance, and that helps me to design the exercise program to be on the optimal intensity and also targeting the right muscle groups. And then I'm going to move more into patient-reported outcome measures. So I'm a co-chair of a group called OMERACT Myositis Scientific Interest Group. So OMERACT stands for Outcome Measures in Rheumatology. And this is an international collaborative group. It got started in the 90s, focusing on rheumatoid arthritis. But now we have, I think, 19 specific diagnosis groups who are working on developing outcome corsets for patients. So here you can see we are represented by the US, Sweden, South Korea, the Netherlands, and Australia. And this has been an expanding group, and I really want to highlight our two fantastic patient research partners. It's Ingrid de Groot from the Netherlands and Catherine Sarver from Baltimore in the US. They are really instrumental to help us understand what we should measure and what types of symptoms are important in myositis. So here we are a group of mainly rheumatologists, but here is me, a physiotherapist, and Malin Regert, she is an occupational therapist, and she's also a member of the medical advisory board. So we have bi-monthly meetings on Zoom, and then we try to get together as often as we can during conferences. So what we had focus groups with people with myositis in the US, Sweden, and South Korea, asking, so how is it to live with myositis? Can you describe a normal day? And so we recorded these focus groups, and then we transcribed them to text, and then we read all the text, and then we extracted meaning-bearing units and made shorter codes of this. And what was very interesting is that in the textbooks, myositis was described as the painless muscle weakness. But we already knew it from our clinical practice that this is not true. And this was really evident in our focus groups that everyone were talking about pain. So these were fatigue, pain, interference, and physical function were the three most common and most important symptoms to measure in clinical trials and clinical practice. So we suggest that these should always be assessed in clinical trials as patient-reported outcome measures. Then if you're doing a study focusing on lung symptoms, then of course you need to assess lung symptoms, or if you're doing a clinical trial where you think you will improve skin symptom, then you need to assess skin symptoms. And here you see a lot of other areas that also are important to people with myositis. So this is kind of a research agenda that we need to look further into. So what we have been doing is validating, first selecting. So now we knew we need to assess pain, fatigue, and physical function, but how should we assess? So we did a literature review to find different scales, and then we selected those that our patient research partners thought were most relevant, and then we sent out online surveys and asking people with myositis. It was in US, Sweden, the Netherlands, and South Korea. So we asked, so which of these questionnaires do you feel are most relevant for you? Which are most feasible? So if you were responding on questions on fatigue, for example, which of these instruments would you prefer? And patients preferred 3 scales from the PROMIS. It's a patient-reported outcome measure information system. So these scales are developed by a huge item bank, and they are validated. Each item is validated. So we have now validated the PROMIS pain interference scale. And here you can see the questions. For example, how much did pain interfere with your day-to-day activities, work around the home, ability to participate in social activities, your enjoyment of social activities, for example. And then the patient is crossing one of these alternative for answers. And we have also validated the PROMIS fatigue scale, asking during the past 7 days, how often did you feel tired? Did you experience extreme exhaustion? Did you run out of energy? Did fatigue limit you at work? And it also, were you too tired to think clearly? And again, ticking one of these answers. And then we also validated the PROMIS physical function, asking, are you able to do chores such as vacuuming or yard work? Are you able to go up and down the stairs at a normal pace? So there are 8 different questions. So we have validated these questionnaires, as I already mentioned, by people selecting these they were able to choose from a multiple number of questionnaires, but selecting these as most relevant and feasible. And we have also made interviews with patients while filling out these questionnaires. And we have also looked at how stable they are over time. So if a person is responding to these questionnaires twice within 1 or 2 weeks, we don't anticipate a big change, and therefore the responses should be quite similar. And all these 3 questions had an excellent retest stability. And we are currently investigating these questionnaires we have done longitudinal assessment to evaluate their responsiveness. But I hope to get back to you with those data later. So I would be happy to hear your thoughts on the relevance of these questionnaires. And I am now moving over to another large international collaborative group called the IMAX, the International Myositis Assessment and Clinical Studies Group. This is, I think we are now about 400 experts, and there are also some patient research partners as members in this group. We have, I think, 7 different scientific interest groups, and I'm chairing the rehabilitation and exercise scientific group. So working very intensively in this project, we are 50 people, 14 patient research partners, and the rest are clinicians or researchers. And we are from 17 countries on 5 continents. And our current project is to try to develop international evidence-based exercise guideline for all people, all subsets with myositis. And to accomplish this, we have reviewed all available literature on exercise in IIM, and we have been first focusing on what types of exercise interventions and what subsets of patients were included and what were the outcome measures. And then we have also reviewed the quality of these papers. And we are now focusing on publishing a writing manuscript on the guidelines for safety. So we want to make it known globally that exercise is safe for all people with myositis. And I think the important thing is that the exercise is adapted and progressed in the right pace. And I would say there are no studies published today that does not conclude that exercise is safe. So I hope we can finish this by the end of the year. And this is the steering group of the IMAX Rehab and Exercise SIG. And here is David Marshall. He is on the, I think he is chair of the board now. And we have Ingrid de Groot, who is another patient partner. And this is Leslie Ann Sackett-Koo, who is a rheumatologist and specialist on interstitial lung disease, who is co-chairing. So then I'm moving more into exercise and why is exercise important. So we have seen that many patients, although responding, having a good effect of their immunosuppressive treatment, many are left with a persisting muscle impairment. They are not reaching, they're not coming back to their original muscle function. And we have also seen that patients are more restricted in muscle endurance compared to muscle strength. And patients are have reduced aerobic capacity compared to healthy controls. And there is a recent study showing that patients with anti-synthetase syndrome or who have lung involvement have much more reduced aerobic capacity than other patients with myositis. So in the literature, myositis is often described as a proximal weakness involving shoulder and hips and the quadriceps, the front of your thighs. But we have shown that patients have about only 50% of expected grip strength, and quality of life is also limited compared to reference values. And coming back to pain in myositis, there are some emerging evidence that many patients do report some amount of pain, and that this is difficult to treat. But we have done individual interviews with people who have myositis. And I can't go into details because it's not published yet. But patients describe that pain could actually be the first symptom of myositis. And then when they got hit with the high doses of corticosteroids, most of the pain disappeared. But then when the corticosteroid doses are tapered down, some amount of the pain can come back. And and it seems like adapted exercise can reduce pain. Overexertion can increase pain. So I think the importance of adapting exercise program to levels of pain and fatigue is very important. And for people with inclusion body myositis, we know that they don't respond as well to the immunosuppressive treatment, and that they have a slow progression of muscle weakness and functional limitation. And as we know today, exercise seems to be the most important treatment for people with IBM until a better drug, better medication can be identified. So in my talk now, I'm gonna mention all adult types of myositis, also including IBM. Although my research have not focused on IBM, but I think it's important to highlight this because there has been some new studies recently. So we have looked into muscle tissue before and after exercise, and been able to show that exercise is safe and can reduce inflammation in adult people with myositis. So we think, it's our hypothesis that exercise is a disease-modifying anti-rheumatic drug. So that means exercise is a medication that you can add on to your immunosuppressive or corticosteroid treatment. We can discuss this later. So when I started my work in myositis, the textbook said it was harmful to exercise. So especially if you're active in a disease, if you're flaring, you should not do any physical activity or exercise. So that was what we knew in the 1990s when I developed my first exercise program. So the principle is to do it as a circle training. So you can do a warm-up, doing a step-up exercise, or you can just walk on the where you're standing, or you can take a walk or a biking or whatever warms you up. And then you do some work with the arms. And we have identified that some patients have a more acute onset with very severe muscle weakness, and then they're not able to lift their arms against gravity. So with this pulley, you kind of do assistive, active shoulder flexion. And you can also train your grips. And then you do some work with your legs, and then with your arms again, and with your trunk and neck muscles, with your hip muscles, and your hip flexion. And it has been shown that the hip flexion is the most affected muscle groups in most people with IIM. So depending on how strong you are from the beginning, about 10 repetitions per task. And you might say, no, only work against gravity, or if the patient has a little better muscle function, you can add on free weights or weight cuffs. And combine this program with a walk and do it 5 days a week. So it means like in total 30 minutes of activity per day. So what we could see with this program is that it improves your muscle function, endurance, and it could improve your aerobic capacity. And we also looked in muscle biopsies before and after this program. And in the muscle biopsies before, we saw that there was a decreased proportion of the oxygen-dependent endurance type 1 muscle fibers. But after 12 weeks, there was an increased proportion of type 1 fibers. So that could explain why patients improved their muscle endurance. It might reduce the CK levels, which is the muscle enzyme that is leaking out of muscle in inflammation or muscle injury. And there were no signs of increased inflammation in the muscle. And we evaluated this looking at inflammatory cells in the muscle tissue. We did magnetic resonance imaging of the thigh muscles, and we in none of these measures we could see any signs of increased inflammation. So we have tested this program both in patients who had their disease for a long time, but also in patients who were recently onset the high disease activity, and they started within 4 weeks after their diagnosis and introduction. And what we could see in a randomized controlled trial that we published in 2014, one group got started with this home exercise program very early, and another group had to wait for 6 months and then got started. And what we could conclude from this study was that those who got started with exercise early, they were also more physically active 1 and 2 years at 1 and 2 years follow-up compared to the control group who had to wait. So we think it's important to get started early and learn how to exercise if you have myositis, and make it a lifestyle. What we could see, although that there are some indications that this program can reduce your fatigue and improve your quality of life. So this is how we have started exercise with patients for many years now at the Karolinska. And then when this is getting easier, we have progressed into other types of exercise. So this is a study that we did some years later. And this included 7 patients who were not active in their myositis, but they had a remaining muscle weakness. So we did 3 sets of 10 repetition maximum. And 10 repetition maximum means the weight that you can lift 10 times, but not 11, 12, 13. So you end up on about 70% of your maximal strength. So we did that in 3 sets with 90 seconds rest in between. And these were the 5 muscle groups that we trained 3 days a week for 7 weeks. And what is important to mention here is that we started on a much lower intensity. So over 2 or 3 weeks, we built up to the goal intensity. And there were a couple of patients here who had arthritis and who had fatigue. And one had a risk of osteoporosis. So during the time, we had to adapt all the time. So if you had arthritis and pain in your hands, you had difficulties lifting the right weight. So it took a longer time, but everyone got there in the end. So what we could see here by using internationally consensus suggested improvement criteria. That is also from this international collaborative IMAX, International Myositis Assessment and Clinical Studies Group. They suggested 6 different criteria. So if you were improved in 3 of those, then you could not worsen in muscle strength, then you could be then you were identified as a responder with reduced disease activity. And this has been used for many years for clinical trials when they're evaluating different medications. But this was the first study where we used these criteria to evaluate the effect of disease activity after exercise. And we looked at gene expression in muscle tissue. And we could see that genes related to inflammation and fibrosis were downregulated after the exercise compared to before they started. They improved their muscle strength a lot, and some also had an improvement in daily activity performance. So this kind of made us a little bit more brave. Okay, so intensive strength training does not seem to increase the disease activity or have any harmful effects. So we went into another type of intensive training, which was more aerobic. And this time we had a non-exercising control group to compare with. So we asked patients to bike on 70% of their maximal aerobic capacity for 30 minutes, 3 times a week for 12 weeks. And then they also did muscle endurance training of their quadriceps. So sitting and lifting up, straightening your knee with the weight cuffs on your ankle. So they did this 30 to 40 repetitions until they were exhausted in their muscles. And the control group did not do any exercise at all. So what we could see that the exercise group improved markedly and statistically significant compared to improve the aerobic capacity. And they also reduced their lactate levels in muscle and improved the mitochondrial function and increased number of capillaries compared to the control group. And the mitochondria, they are kind of the motor of the muscle fiber. It's there where the energy consumption, much of the energy consumption is performed. We could see reduced disease activity using these disease activity criteria, and 10 of 11 patients in the exercise group had reduced disease activity, while there were no changes in the control group. And we did see that genes regulating inflammation were downregulated, and genes regulating muscle growth were upregulated. And patients improved their strength and endurance and reduced their fatigue compared to the non-exercising control group. So this is what we know now in patients with most types of myositis, except not including IBM. And I'm coming back, we're currently doing a study looking into high intensive interval training in patients with newly onset of myositis, but I'm coming back to this. Saying a few words about IBM. So the current research indicates that exercise is safe and that it might slow down the disease progression in IBM. So studies suggest that exercise can improve strength in the less affected muscle groups. For example, the gluteus muscles, the hamstrings, shoulder muscles, and may help to maintain strength in the more affected muscle groups. And those are, for example, the finger flexors, your grip strength, and the front of your thighs, the quadriceps. But we also believe that there might be a chance for some improvement in the most affected muscle groups. And of course, that is depending on how far the disease has progressed. As I'm going into, we have a one randomized controlled trial indicating that those who improved the most were also the patients with the shortest disease duration. And there is a randomized controlled trial from 2019 showing that aerobic exercise and resistance training 3 days per week in a community-based setting markedly improved aerobic capacity in individuals with IBM compared to a non-exercising control group. But there were no changes on muscle strength. But it's you're able to improve your aerobic capacity, which is a very important health indicator. So this is a home exercise program that was developed in Australia. It targets affected muscle groups in IBM. And it's nothing special with the exercise program, except that you should try to do it twice a day and for a 16-week period. And this study could show that patients improved in muscle strength, in both grip strength and the quadriceps. They improved in their ability to stand up from a chair and their walking ability. And there were no signs of increased disease activity measuring these CK levels. So this is an easy program that anyone can do, and this is how I introduce everyone with this program as a startup, and then you can progress into doing other types of exercise. I just want to mention a Danish study published in 2018, where they tried blood flow restricted training in IBM. So what you can see here is, so you put a cuff on the top of your thighs, and then you restrict the blood flow. So you take away 70% of the blood flow, and then doing exercise on a leg press. So this will kind of create an ischemic milieu in the muscle. And this stimulates muscle growth. So submaximal blood flow restricted training have the same effect as a really high intensity maximal strength training in healthy. And since a person with IBM would not be able to do very high intensity maximal strength training, but this study shows that it's feasible to do the submax training. So they included 22 patients who were randomized to either the blood flow restricted training twice a week or to a non-exercising control group. So they had a leg press, they did isolated knee extension, calf raise, dorsiflexion, and knee flexion. And this knee flexion was introduced after 4 weeks. So they did unilateral exercise in 3 sets of 25 repetitions. And what they could see was a slight improvement of almost 6% in the quadriceps muscle. But so this was a very small change, and they said, well, maybe they want to say that this is sustained, no change in muscle strength. But it's very important, I think, when they compare to the non-exercising control group, who declined by almost 10% in the same 12 weeks. So this was the first randomized controlled trial looking into exercise in IBM, and it shows what is happening if you don't exercise. And they also saw some within group improvements in the self-reported function using the IBM functional rating scale, and they also saw improvement in SF36 physical function, quality of life. And now I'm coming into the high intensity interval training. So this means that you warm up and then you do a very short bout of very intensive biking. In this case, they're not running, but they're biking. And then you slow down for 2 minutes, and then you do another set of 30, 45-second high intensity, all out biking. So in our protocol, we are testing 6 30 seconds, very high intensive sets with 2 minutes of rest and moderate biking in between. And this type of exercise have been shown to be as effective or more effective than a continuous exercise on a moderate to high intensity. And there are some studies in multiple sclerosis and heart failure and rheumatoid arthritis indicating that this is safe and feasible. So our study has been ongoing for quite some 5 years. And we have now included our last patients. So from our experience, it seems like this type of exercise is feasible. But of course, it's important to get started on a much lower intensity, slowly 2, 3, or 4 weeks, building up to the goal intensity of these 6 sets. But I hope to be able to come back to you with more results. So there are lots of health benefits from regular physical activity and exercise. There is a strong association between aerobic capacity and health. So if you have a good aerobic capacity, you reduce the risk of getting a cardiovascular disease or type 2 diabetes, for example. So it can improve your quality of life, and it can also reduce the risk of osteoporosis or some forms of cancer. And if you continue being physically active over 6 months, then you can also reduce a high blood pressure. And we know that people with myositis have a higher risk of developing cardiovascular disease. So it's important for all of us to train and be physically active, but maybe it's even more important if you have a myositis. And these are just some examples of organs that you can affect in a positive direction with exercise and physical activity. So thank you so much. I have no idea what time it is. Oh.
You can go ahead and stop sharing. We have about 12 minutes for Q&A. And I have a couple of questions that were emailed in before you get to the ones in the Q&A box. If anybody out there wants to ask a question, just type it in the Q&A. But this person wanted to know, what periodicals would myositis research get the most readership from neurologists and rheumatologists, please?
Can you repeat that?
What periodicals would myositis?
What does that mean? Periodicals?
Periodicals, I think they mean like a journal, whatever is peer-reviewed type of things. So would myositis research get the most readership from neurologists and rheumatologists?
I would guess, of course, we have the arthritis and rheumatology and the annals of rheumatic disease. These are 2 of the top ranked rheumatology journals that I know that everyone reads. And it might also be Arthritis Care and Research. And I think Muscle and Nerve and Neurology are two neurology journals that are important. But now when everyone can, I don't think that you subscribe to the actual paper journals anymore. You just search on PubMed find your articles. And then I think it's a little bit more open to, if you're searching on Myositis, you can find any articles. So I think, was that a good answer?
Yes. And I know you talked a little bit about actual exercises and you showed them in the presentation. But this person wants to know, is this the same exact set of exercises you published a few years ago, or have there been some changes?
Oh, it's the same.
Okay.
But I would say that if you're working together with a physiotherapist, they can help you to maybe add on other exercises and kind of adapt to your individual needs. So it doesn't have to be exactly the set of exercises, as long as the program is targeting muscles where you are affected.
Okay, let's go ahead and move over to the Q&A. This person has a disclosure. I was an NIH science officer on the PROMISE projects. I'm also a patient with PM mitochondrial pathology. They are state-of-the-art PRO assessment with psychometric testing and validation. My question is, what are barriers to use of the PROMISE measures in clinical practice, especially the computer adapted instruments versus the short forms?
I think if you have the availability to work with the CATs, the computerized form, I think depending on, you just have two screening questions, and depending on how you're answering those questions, then you will get automatically a logarithm will give you a set of questions to answer about fatigue or pain. So I think the chance of having relevant questions for everyone, that is one major, what do you say? That's good. But I mean, and these short forms where you have a set of questions that you cannot change, it's very easy to do it on paper and to calculate it. But maybe all items aren't relevant to everyone. So I would say there are pros and cons.
Okay, so is it normal in DM to have significant gluteal muscle atrophy? I've had an MRI following a flare in October, January, which shows this, but no active myositis. I'm struggling to walk up any slope or upstairs. I still have a lot of pain too when I try to walk up slopes in the glutes and lower back area. Would you expect this, or should my doctor be looking for a different diagnosis or treatment? I can't understand with DM if the muscle damage is ongoing subclinically, even after a flare is over. And if so, if I should be on new immunosuppressants.
I think it can be expected. I see that in some patients that they have, because myositis can actually affect first with inflammation and then with muscle atrophy in, for example, the spine muscles or the gluteus muscles. So I think it can be expected. And I think it's important that your doctor try to distinguish, is there any amount of active inflammation in these muscles that you have problems with? And I guess they can do that by looking at the CK, or they can do a MRI scan to see if there is any edema as signs of active inflammation, or to see, is there more like atrophy or fat infiltration in these muscles, and then it's more damage, and then you won't have any help of another immunosuppressive. So it has, and I know that's very challenging for the rheumatologists or neurologists to distinguish between an active disease and disease damage. But I guess if you can, I think it's good if you try to exercise these muscles as well to see if you can improve. And then I guess, I mean, even though you have some fat infiltration and atrophy, exercise can reduce this. So it's not a irreversible damage, I would say.
Okay, and finally, this is not a question, but a remark. Thank you for your presentation and all your excellent research. She is doing great, thanks to you. She has DM, MDA5, and started with the functional index 2, very low level, one arm up only once at first. Then she did the intensive resistance training, and now she does the high intensity internal interval training by doing push-ups every 2 days. And on top of that, she walks every day and feels great. So thank you. She wanted to also comment that she found that stretching gently after exercise helps a lot. She practices yin yoga, which is a gentle stretching that helps. And she only does her exercise every 2 days to allow her muscles to rest in between, and heat also helps. So like all of us in our myositis community, we are very grateful for your research, and we thank you so much for being here. Do you have any final thoughts you wanted to share?
Well, thank you for sharing your exercise regime and what you're doing. I think it's very inspiring to see someone working from a very low level and really go into more advanced exercise. And I think thinking about variety, doing different things. So I think it's good walking and doing yoga and resistance training. So that's really one advice I have. And as long as you feel good doing exercise, as long as you can recover within a fair amount of time, maybe 1 or 2 hours, and don't have increased pain levels, I think anything you're doing is great. As long as you're having fun and feeling good and improving.
All right. Well, thank you again so much for the work you do and for taking the time today to do this webinar. If you would like to see more of Dr. Alexanderson, you can join us for our virtual summit in honor of Myositis Awareness Month. That will be Saturday, May 20th, and you can register online at www.myositis.org. On that first page, you can find the art. All you have to do is just click on the image and it'll take you to the registration page. So we're excited to highlight her experience again, and she will be coming to our conference in September in San Diego, and registration for that is also open. So you're more than welcome to join us for that. So thank you again. And for TMA, I'm Rachel Bromley. Have a great day.
Thank you.